visit with our exhibitors. We have some truly great products and services that are available, and these folks have in many cases traveled quite a way to be here to show you, to talk with you about what they're offering. And we believe those products are truly superb. The Academy, of course, does not endorse anyone's product, but may we just suggest to you that if you have not had the chance yet, please take the opportunity between our break here to go over and visit with those folks. They'll be here tomorrow. You'll be blessed for that time. Are we ready to roll?
We're going to do a little introduction right now. Go ahead. Just read from the card, yeah. The card. Yeah.
Hi guys, this is Dr. Clifford. He's a researcher, lecturer, and information quality instructor. He's founder, president, and research director of Clifford Consulting and Research in Colorado Springs, Colorado. We also have an IAOMT fellowship as past president, 1980 or 1998.
Thank you. May I correct that I do not have a doctorate. I have a master's degree and 38 years in work, and I no longer mislead anyone in that respect. The topic that I was asked to address today has to do with reducing patient risk by screening patients, hopefully ahead of treatment, sometimes post-treatment when problems occur, to be sure that the materials that they have been supplied with are truly appropriate for their needs and use. And in doing this, may I suggest to you that, number one, Clifford Materials Reactivity Testing is provided through Clifford Consulting and Research. I am the inventor, developer of the CMRT regimen. I have direct financial interest in this testing. I own the company. I would also like you to know that the Academy does not have a financial or investment interest in CMRT, in CCR, or in testing, promotion, and marketing. In accordance with the standards of the Academy, we offer these statements in full disclosure so that you know where each speaker is coming from. If you have any questions at the end of the presentation, please don't hesitate to come and speak with me.
The benefits of screening a patient begin with providing some kind of objective laboratory evaluation that is specific to the patient. It doesn't say that product X is bad for everyone, nor that it's perfect for everyone. In our experience, we have never yet found a perfect material. Some will come close. They are in the 99 percentile. Others are down in the 2 to 3 percentile, and I'll leave you to guess which ones those are. But may I suggest to you that one man's meat is another man's poison. And because something does or doesn't work for this patient, should not be construed to mean that it will or will not serve the needs of the next patient in the chair. The screening testing offers a measure of guidance, first in designing the treatment plan before expensive and involved placements have been done, and more specifically, it helps to inspire acceptance of a very balanced and rounded plan of total care. Many of you will note that patients come to you saying, I heard the product X is the only product that's good, and you will use it in my mouth, and you will. And when you try to say, you know, product X is great, but it doesn't work here, it doesn't have the strength, it doesn't have the durability, it's not ductile enough, it doesn't have the fusibility to the porcelain that I want to use. It has the opportunity now with some objective testing to say, here are some things that you have been screened for that I believe will serve your needs, and we can come to a plan of care that's acceptable to you and that I can also work with and professionally say will meet your needs. The testing is also intended to facilitate informed choice and consent. Sometimes patients will come back after the fact and say, you know, you told me that this was going to fix my ingrown toenails, and it didn't. In this case, you have the opportunity to do as the Academy recommends, to always have an informed consent and agreement with your patient that this is the treatment plan and that you both concur in the process and the materials that are to be used. Helps to minimize the risk of adverse outcomes and the necessity of expensive exotic procedures, especially after valuable tooth structure and bone structure have been lost. When you have to go back for a revision after that point, it gets expensive and difficult. Testing can assist in avoiding these measures. Would you notice that I did not say it prevents it? It assists in that, and we'll come to that more fully. And finally, it offers some due diligence that contributes to the total quality care of the practice, can substantially enhance the peace of mind factor for both the professional and the patient. Now let's say something about materials. Do good, reputable materials really pose a risk or a threat to normal patients? They walk in off the street, they have not seen their physician in years, they appear to be the epitome of health. Do I really need to worry about that? We'll have plenty to say about that in the next breakout when we discuss the electrical nature of restoratives. But let me just say in synopsis here that the very finest of materials can pose a problem. If not debilitating, certainly irritating and a deterioration of quality of life. What about simple, straightforward cases? I've got a small occlusal surface that needs tending to. Does this patient really need to pay $245 US? Or if you live in Australia, $335, the transportation of the specimen and reports is higher. Do we really need to spend that kind of money for that little occlusal surface? In honesty, if you know what the patient has used previously, they've gotten along well with it, you're probably just super fine to go right ahead and fix it. If this patient has complaints, has symptoms, has had orthopedic intervention since their last dentistry, you may want to consider even the simplest case a time to screen. Again, in the next hour, we're going to talk about what happens when we put a chrome cobalt knee in place with high-density polyethylene to that beautiful lava crown that you want to put on there. And yes, it does have a bearing. But for these simple, straightforward cases, we know what worked in the past. We're not changing. We're in the same product or the same product family. You're probably, frankly, all right. We'd love to test the world. But is it necessary in those cases? Probably not, unless you have new complexing factors. Can a screening test catch or identify all materials-related problems? Frankly, no, it can't. If it's been an exceptionally long time since patient has been exposed, their antibody titer, which is the goal we're looking for, may be below our detection limits. The patient may be immunocompromised and no longer capable of producing an adequate immune response to give us those antibodies, even with current exposure. And sadly, in some cases, particularly the universal reactor community, they're going to react to a little clean grain of sand, and there's not a thing you will do to stop it. And so, frankly, what does the screening test do? It narrows the band of choices. With reasonable laboratory evidence, it says this material doesn't have any phenol groups, this one doesn't have any palladium, this one has no tungsten, and this one does not have any toluene in it. We can narrow the choices even for those tough patients, but screening is screening. It does not always take you as far as you want to go. What do you need to do to go the rest of the way? We heard Dr. Baldwin talk about porphyrins this morning. There's lymphocyte viability testing, and we specifically mentioned the ELISA testing, or the testing that Dr. Jaffe does in Virginia, the ELISA ACT testing. We also mentioned that there are some other functional tests that could be done. But for quick broad-spectrum screening that currently covers more than 7,800 trade names, or if you're doing the orthopedic panel, about 2,000 trade names. We can help you with some guidance up front based on the existing reactivity in the patient. Product certification, seals of acceptance and approval, identiloid tags do not guarantee that they're going to work for a patient. We should always be aware that even great, normally well-received products become problematic when placed in a biochemically and electrochemically mixed restorative environment. How many of you have had an issue where you've had a beautiful zirconia crown and you bonded it and cemented it with aluminosilicate-based agents, only a few months later to have it fall out? Ooh, I know I do quality dentistry. Those are wonderful products. They work for everyone, right? But electrochemically, they went after each other. And let me bust this bubble that zirconia is perfect. There are some very learned colleagues making that claim. And if you truly believe it, there's this certain bridge in Brooklyn that we understand is for sale at a very reasonable price. Folks, there is no perfect material. And may I bust one more bubble before we go any further? There is in nature no such animal as a metal-free restorative. Who slept through freshman chemistry when we had the lecture on anions and cations? Cations are nearly always metals. You gotta have both. Physics and chemistry say they've gotta be there. Granted, in the ceramics, the porcelains, the glasses, the composites, we certainly have wonderful products where the metals are fully oxidized. They are in crystalline matrix structures. They do not tend to readily dissociate. But don't let anyone ever pull the wool down by advertising to you, and then you repeat to your patient, this crown is metal-free. The metal in zirconia is zirconium, and there's probably some yttrium, maybe some titanium or tungsten, and occasionally we'll have some barium. It is not unusual to see a little boron mixed in there, and while we're at it, lithium and iron may well be present too. I don't call that metal-free. Can we bust that bubble quickly? I would also like to bust one other bubble quickly. Aluminum. If you are exposed to aluminum, you will be struck with Alzheimer's. Almost becomes religious, doesn't it? 2 to 2.5% of your skeleton, normally, naturally, and routinely, is aluminosilicate and aluminum oxide. Unless you are being murdered by your skeleton, I submit there are some forms of aluminum that aren't bad. And may I also suggest to you that there is more aluminosilicate available in a single side serving of fresh green garden salad picked up from the soil by the plants than you are likely to have come off an entire mouth of aluminosilicate ceramic in many, many, many years of normal wear. Now, we can break off microfines of any restorative, but folks, the aluminum is bound in a manner that does not readily dissociate under biological conditions. With heat, with a nuclear reactor or a linear accelerator, sure, we can bust it apart, but you're not going to do that in the patient's mouth. And so let's get rid of this idea of aluminum. To be certain, aluminum chloride, oxalate, sulfate, phosphate, nitrate, we get super excited about. But if the only form of aluminum in a product is aluminosilicate or aluminum oxide, we totally ignore it, unless the patient also happens to be silicate sensitive. And yes, there are a few out there. They are bubble dwellers. And it's a sad condition. But short of that, aluminosilicate is not an issue. Now that we've popped some bubbles, the material safety data sheet and the ingredient list on a product does not always reflect the nature of the finished product. Chemical structure and form are far more important than the absolute chemical content. Your patients will come in with an MSDS that says, look, see that right there? You're trying to kill me by what you're using. And no, you are not. We would only suggest to you that you make sure your patient understands that the bisphenol is not likely to be an issue for the following reason. It polymerizes into a structure that does not leave it chemically active. If you're a sloppy dentist and you don't cure properly, you don't mix when it says 1-to-1, and you're sloppy about what you put together, your patient will have an increased range of exposure during the time that things should be cured. I have a little slip with me. This one happens to be from Estelite Flow Quick. There's a nice little table down here, and I'm sorry we couldn't get enough density on it to put it into a slide. But let me just say that if you're using a halogen light, there are 3 different wavelengths, and they have different curing times, and the manufacturer tells you how to alter the time you leave the light on. If you're using an LED, there are several wavelengths, and the manufacturer tells you how to alter the time for the cure. If you happen to be using a plasma arc, there's yet another part of the table, all with the same product. Now, I'll use that only as an example. There may well be other great products out there. But the fact remains, the careful quality of dentistry, the careful practice and application of technique are the salvation of your patient as far as bisphenol and the estrogen mimic. Can we guarantee that we'll all be bound? No, we can't. But at a minimum, a properly placed and cured composite is 4 to 5 orders of magnitude lower risk than an amalgam. Now, patient, there's a small, tiny option that you might have this, and we can do some CEREC crowns and minimize certain factors, but the bonding agent and the cement are still going to use the bisphenols. Oh, but I've got an MSDS. See, it has no bisphenol in it. And they all lived happily ever after. Some don't come with the stuff from the manufacturer, it's true. But it forms in the intermediary curing chemistry. And bisphenol isn't the only nasty. I don't want to get the news media going again. And all of you have had that recently from your patients. Let me just suggest to you folks, if you use the same precautions when you're doing a composite that you do when you are taking amalgam out, and you are a careful, meticulous dentist and do things right to the T, your patient is not likely to have an issue. And frankly, the rate of problem is less than with gold alloy bridges, certainly with amalgam. With all ceramic, we're in a different set of problems, but don't believe that they are problem-free. There is some great work that can be done with composites, and even someone who has cancer and they're scared to death of bisphenol and the estrogen mimic can still be very well served if we are using a good composite. Intact materials are almost never a problem. If we get them stay together, we could all go home and just have a party. Properly reacted constituents are generally not a problem. Complete similarity throughout the mouth reduces potential problems. You have office hoppers. Dr. A put this in, Dr. B did this bridge, Dr. C did these incisals, Dr. D did that over here, and now I'm Dr. E, and I'm going to use my pet product. That is a disaster looking for its time to happen, because materials, any one of which would have been perfect for this patient, are galvanically active against each other and will offload. They will corrode, they will discolor, they will crumble, they will turn loose and come out, and in sadly too many cases, they cause super irritation. Seldom do we ever get a phenol-reactive patient that has a systemic issue from dentistry. It's nearly always a surface phenomena. They get sore or reddened or indurated right at the point of tissue contact. And that's where we need to be careful in the kind of dentistry. We try to find out what they've already got and then stay with it. And if that means that we've got to go find a product that we don't carry in inventory, it may mean that. But for the interest of the patient, we don't want to pick a mixed modality product. And frankly, reduced metals have very different characteristics from oxidized metals. Reactivity and toxicity requires acquisition of one or more thresholds. The patient does super with 3 crowns, but when the 4th goes in, we have just enough release to cross a barrier. There's no more compensatory place, and the patient now reacts with the product. What happened? We finally saturated their ability to compensate. And you know, if we can just get them back under threshold, they will be symptom-free. Can I let that one sink in for just a second? Doctor, this thing just hurts like crazy in the morning, but by the afternoon it's just fine. But tomorrow morning it hurts again. With the circadian rhythms of hormones and flow and other things, we have levels that are bouncing and they're right at threshold and they bounce back and forth. If they go above threshold, you have the symptom. If they drop under, I'm just fine. So we can take some of the acid out by eliminating the tomatoes from the diet and maybe do it without ever touching anything in the dentistry. There are other useful ways that we can help that patient. Symptom and loss of function is not linear, and we can facilitate via body burden reduction. If zirconia is the crown of choice and the 4th or 5th one is the one that triggered a problem, get them off the antiperspirant that has zirconium aluminum chlorhydrate and get them on a deodorant instead. Just removing that much zirconium from the continuous exposure may allow you to use that all zirconia bridge. And gosh, they're beautiful. Some really neat stuff being done in that area. Sporadic symptoms we have mentioned. Corrosion byproducts are the ones that the patient has to deal with. They don't deal with what's inside the tooth. Outgassing and offloading, improper and incomplete mixing and curing, and dissimilarities and mixed etiologies are the creators of the vast majority of problems that patients have in tolerating materials. Now, I'm going to say something and wash my mouth out with soap. Even lousy amalgam would be safe if it stayed together. It doesn't at all. Microbial presence, the bugs love to throw their waste out, and that waste has marvelous capabilities to alter the terrain of the filling, of the crown, of the structure, of the bridge work. And when it does, we have dissociation and bioavailable byproducts. Diet, patient history and questionnaire, and an implant list from the entire body will help you to know what can be done to assist the patient in the greatest way, perhaps even more than our screening testing can. What have they used in the past? What has given them problems? Did they have a problem with a previous dentist? And if so, what seemed to cause it? Oh, the anesthesia. Oh, lidocaine with norepinephrine. And you're metabisulfite sensitive. The preservative is the issue, and you could still use lidocaine as long as you get rid of the vasoconstrictor. They generally do not have a preservative. if there is no vasoconstrictor. And if you do choose to do testing, we have 9 common preservatives that we look at for you. Most patients do not have enough exposure to the native anesthetic molecule that we can depend on an antibody response. But the preservatives are everywhere, not just in that injectable. And that's why we can help you, and that constitutes 90% of the problem. The vasoconstrictor, 7 or 8%, only about 2% or so of the problem is the native anesthetic. Physical exam and clinical sensings, laboratory testing indications, and materials knowledge will also go a long way to helping the patient avoid some issues. May I suggest to you, and we're going to talk more about this in the next block, but when you do your perio charting, start charting irritation. Out on the buccal fold or wherever it occurs, along the tongue, start charting irritations. We'll tell you in the next hour why that is so. Adverse chemistry aspects, alteration of physical tissue structures, infective and microbial issues, electrogalvanic consequences, and esoteric field effects all combine to create problems with modern restoratives. You can begin to see how in many cases your management and good dentistry are going to take care of a lot of these problems. And screening the patient with testing before the work can help pick up the loose ends that are not obvious. We want to, in fact, look at the patient's history. You may want to do some patch or pellet testing, especially if you've got an allied physician that'll work with you. Inhalation and sublingual challenges, electrodermal evaluation, kinesiologic evaluation, and cytotoxic testing have all been shown to help to define why a patient's having a problem with a material. The ELISA ACT and MELISA testing, lymphocyte viability alteration, necrosis evaluation, porphyrin testing. I was so glad to hear Tom Baldwin today. We happen to believe in porphyrin testing. It picks up to do things that we cannot do in screening. And I cannot tell you enough how excited I am to find that these doctors, several of them working together, have submitted a split specimen to several porphyrin labs. I have no interest in the testing lab that Dr. Baldwin mentions. They are here at the booth area. They have found one that consistently reproduces on the same patient, coming from several doctors under a different name. And so I think we've found a reliable porphyrin lab. And passive antibody detection, and that's what we can offer. It's the post-toxin secretion detectable. It's repeatable and demonstratable, even if the substance is no longer in the body. The basis of this work came back during the Vietnam War period when I worked in military lab. We had soldiers who had been exposed to various toxins, but for compensation and long-term care purposes, disability considerations. We go back and we cannot find the dioxin or the bot toxin or whatever else we want to talk about in the patient. But you know what? Their immune record and the antibody record verified that it had been an adverse exposure and that it had taken place. That was a tool that says I don't have to find the offending substance. It might already have been eliminated, but I know they don't get along with this. That's the foundation of what we're doing in testing today. Classical laboratory methodology, we don't care where you got exposed. The nickel may have come from a cheap watch band that you wore for 20 years. But if we put anything in the way of a stainless steel in your mouth that has nickel in it, you're not going to get away with it any more than the red rash under the watch band indicated you were getting away continuing to wear the watch band. Broad spectrum findings, I can look at the chemical group and family reactions and pretty much tell you how the patient's going to deal with green widget composite, because it's what comes out of green widget that we're concerned about, not what's in the intact material. It's the stuff that separates that patient has to deal with. And finally, we can store a specimen and freeze it if we need to, and come back later and use it for comparative if we need to do that. These are qualitative findings only. I know that there are those who try to do serum testing and they try to say, this is least reactive, this is most reactive. When I hear that, I wonder who skipped that lecture in freshman immunology. And I'll explain that with a chart here in just a moment. There is no degree of reactivity data that can be done from antibody detection work. Now, certainly if you get into the ELISA ACT or ELISA test, those things are very quantifiable. Cross reactions are possible. If you react with cadmium, I promise beryllium will show positive too. Those two interact with each other's antibodies. It's all right because we think it happens in the body too. False negative findings, you haven't been exposed for a while, your antibody titer is down, we're not going to see it. I wish that was correctable, but frankly, there's no way to get around it. And what we're going to do is help you narrow the field, but you may need to use some other methods available to you to further refine it. And not the least of those will be looking at what's already been placed and successfully used. Positive false finding or false positive findings, yes, cross-reactivities can happen, and in the universal reactor patient, they react all over the map. It is totally sporadic, and I can test the same serum in 10 minutes and get a totally different finding. The serum is violently alterable. Reduced value with the universal reactors. Challenges have to be in a soluble or miscible form. We use a microtiter environment for testing. We introduce a small quantity of patient specimen, controlled incubation, spectrophotometric evaluation, visual inspection of the plate. There is a way to differentiate between agglutination and precipitation, and it's important to do that. That's why we not only read the thing on the machine, but then we eyeball it, and we need to do that routinely. How do we get the data to tell you whether this product really is usable or not? The MSDS, or product insert sheet, tells us there's a real product and who puts it out. We go to the 510K filings and other equivalents from both the FDA and the European Union. We look to the manufacturer's research and tech departments, and some of them are super good to work with us. I would like to tell you that we have one metal house that is absolutely stunningly superb to tell us anything we want, and in fact, you can go find it on their website, and that's Argent Metals, and they happen to own 7 or 8 other brands. Chances are good your stuff is coming from them. I don't promote them, I don't have an interest in them, I'm not being remunerated for saying that. I'm just saying when it comes to downright honesty and telling you what's in the alloy, they will do it, right to the percentage. We have some associations that maintain databases on a private basis. We have paid memberships and we participate in these. We go to the published research literature and see who worked on the stuff 10 years ago when it was at such and such a university. And we can find out, therefore, what's in it. And occasionally, we actually will send a specimen out for physical testing. That will run anywhere from $1,500 to $3,000. We don't do that routinely unless it's absolutely necessary. It's an exciting new product, and they won't talk to us at all. This little graph will tell you why we are concerned about people who say least reactive, most reactive. The amount of precipitate being formed, we're going to hold the protein constant, the globulin and the like, and the serum, and we're going to increase the antigen concentration, the acrylic, the mercury, the cadmium, the phenols, the quinones. As we begin to come close to an approximate equality of antigen and antibody, we start to get a precipitate. By the time we get to the top, we have a zone match of equivalence. And that does not tell me how sensitive they are. It says at that point I have an equal amount of antibody and antigen. Now, if I keep adding more antigen, the precipitate starts declining. Now, we can stick this on our plate reader. The one we used cost us about $42,000. It is not a simple one. It is research grade. It produces numbers to 5 decimal points if we need it. Are you least reactive because it was here, or least reactive because it was here because the number on the machine here is identical to the number on the machine there? Even if I did an endpoint titration, all it would tell me is you've had a current exposure if that thing is high. It's like a rubella titer. We're working in the same class of antibodies. For moms that are expecting, have you been exposed to rubella recently in your first trimester of pregnancy? We do that by looking at the antibody titer. If it's high, mom has some risks. Mom and doc then need to talk about those risks, and do I want to accept these, etc. In no way does it tell me that this product is least or most reactive. And if it's been a while since you've been exposed, guess what? The antibody level is down and gives a very minimal reading. It's still within the positive zone. It will be reported as reactive. But the moment it hits your system and you have a secondary immune response, the antibody is going to go like that in a secondary response. People, when you see something that says least reactive, most reactive. Now, let me clarify one other issue that's just recently popped up. We're tight on time. Learned colleagues have said you don't have a test. When you mix protein and chemical out in the air, they precipitate. And that's what you're calling sensitivity. That first appeared in an article on the Quack Watch by the infamous Dr. Barrett's. Point 1, there is a quantity of metal, as an example, a metal salt that I can mix with serum, and it will precipitate. You learned that in freshman immunology. But if you get down into the low concentrations, and we're talking now, and yes, I'm giving away some trade secrets, 25 to 50 parts per million in the challenge, you have a whole new reaction area, totally unrelated to this nonspecific monster over here. When someone tells me that's all that's happening, it tells me they didn't bother to go to the lab and look, because there's an entirely separate reactive area that is immunologically active. We are not just precipitating protein. Point 2, if I take a patient, and I'm going to pick some things out of the air that I know to be sensitive to aluminum, to copper, and to cadmium. I take some patient serum and I react it with these low-level challenges of aluminum. It precipitates. We centrifuge it, pull the solids out, the precipitate, And yes, we find the globulin, we find the aluminum, maybe a little bit of albumin, not much. And what do we find back over in the supernatant fluid? We still find lots of globulin. If we'd been non-specifically precipitating, folks, it wouldn't still be there. We can keep adding aluminum until it will not form any more precipitate. And there is still globulin in that supernate. Now I come along, and in the same supernate, I throw in some cadmium. Oh, got a whole new precipitate. We go through the routine again. We pull it out. What's in the precipitate? Cadmium, globulin, maybe a smidge of albumin. And in the supernatant, we've still got globulin, albumin, and all of the other constituents. We can react that again and again with cadmium to the point that we are getting no more precipitate. But then I come along with copper, and guess what? We have a whole new range of activity with precipitate. Now notice that we look at the copper, and yes, in the precipitate there's copper. Do we find any cadmium or aluminum? Only the tiniest traces that you can pick up by mass spec or by ICP that are carryover that the centrifuge couldn't separate, but it is not associated with the globulin because those antibodies that were specific to cadmium and aluminum are already gone. Point 3. To be licensed to do this in the United States, we need a lab license. Because nobody can sell us kits and reagents, we have to make our own. We also have to do our own quality control, and it puts us in a category called high complexity. We are responsible for our own QC. And that means that I must have a demonstrable negative control into which I can put any of my challenges and get no precipitate at all. How do we do that? We do it with fetal serum, fetal bovine serum to be exact. It has the full complement of serum proteins, globulin, albumin, all of the other components, but the globulin is not yet programmed. There is no specificity. We have a negative control that won't react with any of them in the ranges that we work in. When I hear people make these accusations, I look and they're coming from people who never bothered to come and visit the lab. They are people who obviously from their statements have never gone to their own lab to try this. Let me tell you, we started doing this back in the Army years ago. It works. Folks, it's been a pleasure to visit with you today. I would suggest that there are ways that we can maybe help you with screening. We cannot answer all of your problems, but we can answer a good number of them. And I hope for some of your patients you'll consider using it. We'd like to have that as our company. But from a purely professional standpoint, we believe that there is a service. And more recently, the orthopedic surgeons have started using it for the orthopedic panel. Good to visit today.
What a pleasure. I'm Ray Hayes from Charleston, South Carolina. We've been using you for a long time. You give us fantastic service.
Thank you.
I have a question. You were talking about the reactivity and materials to use on a patient.